Good afternoon to everybody, and welcome to this very interesting session on HIV and co-infections. I am Cristiana Opra. I'm an ID clinician and HIV clinician at Victor Babeș Hospital, Bucharest, in Romania. And I will co-chair this session together with Annabel Bedley, who is a technical officer in TB HIV programs at WHO. This session will focus mainly on hepatitis A, B, regarding latest epidemiological data, prevention, treatment issues, and also on TB. And now I will invite my co-chair to present our first speaker.
Good afternoon. Please welcome Philip Yi-Chung Lo to the stand. Dr. Yi-Chung Lo is an infectious disease specialist, currently serving at Taiwan CDC as Deputy Director General and the agency spokesman. His main public health roles also include supervision of national HIV and TB programs. His research focus includes emerging infectious diseases, including sexually transmitted infections that have emerged or re-emerged amongst people living with HIV. His book, Heart Valley, written in Chinese on HIV-related medical, psychosocial, and life issues, is one of the must-to-read for people living with HIV and their family and loved ones, and for frontline workers in Taiwan. Please, Dr. Yi-Chung Lo.
Thank you, Chair. It's my honor to speak here. I think it's uncommon for a invited speaker from a small island from my country, Taiwan, to be able to speak in such a large occasion. But the reason I can stand here to talk about hepatitis A is we have just experienced a large outbreak, mainly focusing on MSM population. And this outbreak further on was linked to outbreak of the similar situation among MSM in the European region and also in the United States. So I'm going to give you a few thoughts on our experiences of controlling this outbreak, especially during a very difficult or sensitive timing when the LGBT marriage legalization movement was carrying on in Taiwan during the 3 years of the outbreak period. So how this social phenomenon was mingled with outbreak control became a very sensitive, also very interesting issue, and I will share our lessons learned with you. As you may know, hepatitis A is a vaccine-preventable disease caused by the virus hepatitis A virus, abbreviated as HIV. Infection is usually self-limited in children, but more severe in adults. The case fatality rate is generally low at 0.1%, but can be higher among those or elderly or immunocompromised populations. The virus is transmitted via fecal-oral route, so it's usually considered as a foodborne or waterborne disease, but can also be transmitted person to person, for example, in sexual settings like oral-anal contact. There has been no specific treatment for hepatitis A available, but the vaccines are highly effective. Here is a map showing from the global north perspective, the countries that could be endemic of hepatitis A from a travel perspective. So if you are a citizen from those global north country, you want to travel to those countries labeled in yellow color, your travel clinic doctor would advise you to give a vaccination of Hep A before going to these areas. However, in these global north countries, the Hep A exposure is low, so the seroprevalence or the seroprotection has been decreasing in these countries over the years. That leads to a growing number of susceptible populations in these countries as well. MSM has been listed as one of the most at risk population for Hep A since 1970s because outbreaks have been identified constantly or on and off from the European region, North America, or Australia. The outbreaks are mainly caused by direct oral anal contact during sex, but can also transmission be caused by contact with fingers or objects that have been in or near anus of an infected person. Recent research has shown that at least 70% immunity among MSM are needed to prevent sustained HIV transmission and to control outbreaks. But vaccination coverage rate among MSM has been low, even in these low endemicity settings like global north countries, ranging from 20 to 40%. And that leads to a low seroprotection or seroprevalence among MSM globally, varied by age or cities, ranging from 14 to 68%, mostly lower than the 70% immunity threshold for outbreak control. Almost 1 year ago, the WHO issued a unique alert on HIV outbreaks, mostly affecting MSM in the European region and in some of the American countries. In this alert, WHO mentioned seeing unusual increase of Hep A cases since June 2016, affecting mainly MSM in low endemicity countries through sexual transmission, mostly oral anal contact. In the European regions, in 15 countries, they have seen more than 1,000 cases when the alert was issued, and that was linked to 3 multi-country outbreaks in the European region. In the Americas, most of the cases were identified from Chile, but also they have been seeing increase of cases in New York City, United States as well. Although in the alert issue, there was no mentioning about the condition in Asia, but when we look at the timeline, you can trace back the beginning of the outbreak actually to the report of Taiwan in June 2015, and then Hong Kong. And in 2016, we know the European regions have suffered from a large outbreak of Hep A, mainly among MSM. But later on, you'll find a similar scenario in Israel and in Chile. And in last year, 2017, the United States followed. And are these outbreaks linked together? So the molecular studies show that this could be linked together, these cross-continent events. So the European study showed that there are at least 3 different strains of hepatitis A virus circulating during the outbreak period. The major strain, labeled in the blue color, was thought to start after the Euro Pride, which taken place in Amsterdam 2016. The second major strain, labeled in the pink color, was actually found to be identical to the previous circulating strain in Taiwan's outbreak and the later on outbreak strain circulating in New York City. So the virologic genetic studies show that these outbreak events could be highly linked together. So I will take some time to give you some ideas about this outbreak, the key population, MSM, and the circumstances of this Hep A outbreak, background information in the East Asian region. As you might be aware that the MSM population in East Asia is still highly stigmatized. So, for example, for the HIV hepatitis A seroprevalence study, there was a study carried on in Taipei metropolitan region looking at the seroprevalence rate of Hep A among young MSM regardless of their HIV status or not. And this showed that less than 10% of the young MSM in Taiwan were seroprotected for Hep A. And the government of Taiwan has since recommends MSM receive Hep A vaccination, but uptake was low because there has been no program supporting that, and the low awareness of the importance of getting Hep A vaccine. And probably most importantly, the cost was not very cheap. 100 to 130 US dollars for 2 doses are probably considered too much for young MSM that can use the money to watch more movies or go to more parties. And on top of that, also, I think the problem is the HIV vaccination can only be provided through healthcare providers. And in order to meet that recommendation, the young people has to admit or disclose their sexual orientation or sexual behavior to their healthcare providers. And that kind of disclosure is very uncommon in the East Asian setting because of fear of stigma or discrimination. So with that background, in 2015 June, we started to notice 5 Hep A cases reported from the Taipei area. And later on, month by month, we see more and more cases. In the beginning of the outbreak, you can see from the right upper side, the orange color indicates patients that are HIV positive MSM. You can see the proportion of HIV positive MSM among all the diagnosis HAV cases increased from 0% to 26% in 2015. And when the outbreak reached the peak in 2016, the proportion further increased to almost 50%. So this outbreak really focused heavily on HIV positive MSM. What about HIV negative MSM? We don't have very good data on that, but through the sampling survey of those who do not have any HIV reporting records in our system, we found that we estimate that about 10% of the blue bar that indicates patients that are not HIV positive MSM might be MSM. So totally, we estimate that approximately MSM could account for 60% of the outbreak cases occurring from the 2015 to 2017 period. And if you look at the lower end, the chart, you can see the map of Taiwan. And the outbreak starts from the 5 major metropolitan areas in Taiwan, and later on spread to more and more rural or county areas, but still heavily focused on the most populated area in the northern Taiwan, the Taipei metropolitan area. And that correlates with the concentration of or the distribution of MSM in Taiwan as well. So seeing that outbreak of a vaccine-preventable disease as a medical epidemiologist and a public health government official, the solution lies in how to give vaccination to the targeted or the at-risk population during an outbreak in order to control that. The problem is how can we identify those who are at risk and deliver vaccine to them without stigmatization or revealing their identity during such a sensitive time of LGBT right campaign in Taiwan. So on the lower end, you can see 2 pictures showing the divided society, even at the moment, that the LGBT marriage legalization campaign has been ruled legal by the Supreme Court last year, almost 1 year ago. But still the conservative groups, they don't like the idea. It's like a 50-50 divide. So there is going to be a referendum at the end of the year for people to vote for or against LGBT marriage legalization. So that campaign has been since 2014, 2015, when the outbreak started in Taiwan. And we were very sensitive or careful about not to do the public communication campaign jeopardizing the LGBT right campaign. Because if we say this outbreak is focusing or mainly affecting MSM in Taiwan, the conservative group can easily blame MSM for causing the outbreak and stigmatizing MSM with contagious diseases or outbreaks. While we want to do the vaccination campaign, we still need to identify those most at risk. Like in Hong Kong or in the European region, the strategy is to distribute Hep A vaccine through the LGBT-friendly clinics or social participation groups. We have those LGBT health centers and the social participation groups in Taiwan as well, but they were also very cautious about giving out that message that this vaccine is only for MSM, and the only MSM is required to get the vaccine. And also to get the vaccine, MSM will need to reveal their sexual identity to healthcare providers or to the social participation groups as well. So we determined that during that sensitive time, it's probably not going to be eligible. So instead of placing or targeting MSN, we decide to instead targeting patients with HIV or STD, and we can use the medical reasons to support the idea of government-funded, free-of-charge Hep A vaccine to the vulnerable population. So that campaign turned out to be very successful. So the government decided to purchase a large quantity of the vaccine and give free of charge first dose to persons reported with HIV or newly diagnosed syphilis or gonorrhea. Starting from October 2016, you can see the rapid decline of cases of the outbreak. So by the end of 2017, we almost have none HIV positive MSN reported with newly diagnosed hepatitis A. And as 2018 now, the outbreak is over. And we are now going back to the baseline of the travel-associated Hep A scenario. This graph shows the vaccination coverage by time during the 1-year campaign period. So over the period, we were able to raise the coverage rate from 34% to 70.3%, reaching the 70% target. The different color indicates different targeted groups like HIV or patients with syphilis or gonorrhea. And thanks to the collaborating hospital, more than 400 hospitals and more than 1,000 physicians participated in this campaign and provided the vaccination to more than 18,000 recipients. So lesson learned through the outbreaks in Taiwan, and there has been a few publications already published from the Taiwan Medical Society, hospital-based or community-based studies. I encourage you to read those publications if you are interested. Of course, high vaccine coverage is crucial to control the outbreak. So the study in Taipei City showed that the vaccination rate quickly raised from 4.7% to 70.6% within just 1 year. And with that surge of coverage, a steep decline of incidence was seen rapidly after proportion of immune subjects reached 65% or higher. So that demonstrates the importance of getting that immune threshold to reaching 70% or so. And there was concern about the effectiveness of HIV vaccine among HIV-infected individuals because of immunosuppression. Could vaccine be less effective than other people? But the experience from our outbreak shows that the vaccine was highly effective, 96% effectiveness. And the seroconversion rate, which means the vaccine response, was even higher if the patient is younger or the patient has undetectable viral load. But the outbreak is not just HIV and HIV alone. There were more to deal with. There were many other co-infections that were commonly seen among the cases, like syphilis, gonorrhea, Hep C, and the shigellosis. And also from those patients with only newly diagnosed Hep A, we found that 35 of these cases later on were newly diagnosed with HIV as well. So we were able to detect new HIV diagnosis from Hep A patients. So how good and how soon could the serologic response after Hep A vaccination happen among the persons with HIV? So the serologic response overall at the end is similar to people without HIV, but the serologic response or the vaccine response is delayed. If you look at the graph, you'll see the antibody response by week over the 2-dose period. After the first dose, the antibody response gradually increased to around 60% in 6 months. That means about 40% of the individuals, HIV positive individuals, were still not producing an adequate antibody against Hep A to provide adequate protection. So the second dose is necessary. The second dose can boost up the antibody conversion rate from 60% to more than 90%. So second dose is essential. there were also other vaccine issues dealing with this outbreak. So in the outbreak, we found a few breakthrough Hep A infection even after vaccination. And generally, we expect that the vaccine would take 2 weeks to be effective. However, we found that even after the 2 weeks, still 5 patients developed Hep A infection. That could be caused by the inadequate antibody protection, about 40% among the HIV-infected individuals. All of those 5 patients, they only received 1 dose of Hep A vaccine, and they developed the illness 1 to 6 months after the first dose in vaccination. So you have to be cautious that the protection is not 100%, but it's at least more than 99% already. And also, because of shortage of the vaccine in the market, there were 2 big manufacturers, GSK and the MSD, and GSK was experiencing some shortage of vaccine in the Asian market at that time. So we were only able to acquire the MSD vaccine Vacta. And the interchangeability became an issue. If the patient received GSK vaccine at the first dose, it's okay to take the second dose as another brand name. And we found that the similar seroconversion rate at around 80%, 90% at different weeks. So the 2 vaccines are interchangeable. And the last issue was a question about how long can the vaccine last among HIV-positive individuals. So a longer-term study was carried out by the National Taiwan University Hospital since a few years ago. And luckily, we were able to get that data recently that 88% of the vaccinees still had adequate seroprotection after 5 years. And those vaccinees, they were all HIV-positive individuals. So I think we can say we can be very confident that Hep A vaccine is very effective even in HIV-positive individuals. And also the response is durable. So the question still relies that what about the HIV-negative MSM? Because in our scenario, we only provided the vaccination to patients with HIV and patients with newly diagnosed STDs. And unlike the campaigns in UK or in Hong Kong, they can put out a poster addressing the association with MSM and the Hep A outbreak. We were not able to do so because of worrying of being an intervention or being seen as a jeopardizer in such an LGBT movement. So, and the problem is still that after the outbreak, we reached that certain 70% threshold, but that protection is going to wane as well, year by year. So a decision in our immunization expert group carried out about looking at this outbreak and the future risk of the young adolescents. Can we think about incorporating Hep A vaccine into the childhood essential immunization program in Taiwan, so we don't need to differentiate who is MSM and who is not? And starting from January this year, the Taiwan government decided to incorporate Hep A vaccine as the EPI in children. So all the children born after January 2017 were eligible to receive government-sponsored 2 doses of Hep A vaccine when they reached the age of 12 months to 15 months for the first dose, and 6 months later, the second dose. And I think that's going to provide a long-term seroprotection against HIV in terms of long run, regardless of the sexual orientation or identity when they develop and enter adulthood. So I would also encourage you, if you have time tomorrow afternoon, to join another session on hepatitis. You'll hear from 2 scholars from Taiwan reporting their research associated with a Hep A outbreak in Taiwan. The first one is going to be presented by Dr. Lin Guanying on the vaccine effectiveness. And the second one is Dr. Li presenting the clinical course difference between HIV and the non-HIV co-infected individuals. In conclusion, I describe a very interesting and unique Hep A outbreak among MSM, highlighting the importance of vaccination program and also highlighting the effectiveness of vaccination program, even among HIV positive individuals. But the question still rely on, during such an outbreak, we use targeted approach, but should we target it only towards MSM or towards HIV? And that's going to be mingled with the social phenomenon that was very unique during the time of LGBT marriage legalization in Taiwan. And later on, we decide to give actually universal vaccination in order not to stigmatize certain population, only necessary for certain immunization. And the trigger of the outbreak, or the underlying cause of the outbreak, still remain unclear. Why did that outbreak occur in 2015 to 2017, but not earlier? Because from the previous study, we know the seroprevalence was already low in the early 2000s. But still, there was no such outbreak decades ago or a couple of years ago. So we were thinking of the relationship between emerging recreational drug use, especially chemsex, associated with methamphetamine or other related drugs that became an emerging phenomenon among the MSM population in Taiwan. Could that be linked? We have some data of association with of chemsex with shigellosis, and shigellosis was also a co-circulating outbreak infection during the Hep A infection, but we don't have direct evidence linking chemsex to Hep A. But that's a theory that we can work on to prove. So still a lot of social behavior factors behind this outbreak need to be determined. And I would say that 2-dose vaccines are highly effective among persons with HIV, and that's the most important lesson learned from the outbreak in Taiwan. And thank you very much.
Okay, thanks very much. That's a really fascinating talk and a brilliant case study of how to respond to an outbreak, and some very encouraging evidence there as well in terms of prevention amongst people living with HIV. We've got time for questions right now, so please, if you could come up to the microphones and if you have any questions.
Until people will come to the mic, I will ask you if you showed us that Hep A vaccine effectiveness is very high, but you told us also that it's more in patients with undetectable viral load and higher CD4 cell count. Do you think that it would be in patients that are not seroconverting, this low percentage, do you think it would be useful to revaccinate after the increase of in CD4 cell count and undetectable viral load, undetectability in these patients? Do you think it would be useful to try to revaccinate?
Yeah. Thank you for the question. Actually, I think a research group in Taiwan has been working on the solution to that question. And the answer is probably yes, because when we see that 88% of the vaccinees who are HIV positive still have durable protection level after 5 years, there are still that 12% that need to be considered still remaining at risk. So the research that was carried early on in Taiwan shows that a 3-dose HIV vaccination can lead to a higher antibody level, but the similar antibody protection rate among HIV-infected individuals. So the take is that if you give 3 doses, you can help those with weaker or less durable response to reach a higher antibody level in the majority of the patients. But yet, if you use the cutoff of antibody positive or negative rate, the antibody positive rate will still be similar to the 2-dose. A longer-term follow-up is still ongoing, and we look forward to more data from that research group in Taiwan.
Yeah. And you mentioned about chemsex. Do you have this problem? Is this also a problem in your region, in your country? Because, as you know, usually in Western countries, and we notice the increase in hepatitis A in these groups and in this MSM group. So is this also a problem in your region?
Yes, cancer is still a problem in Taiwan, not only in England or in the rest of the European region. We are seeing more and more MSM and non-MSM using methamphetamine to facilitate sex. And there was an interesting time coincidence that because ketamine was the most commonly used or most popular substance among MSM before 2014. But the intervention, I think because of United States drug control effort, they asked the Chinese government, the mainland China government, to control more strictly on ketamine illegal production and illegal exportation. So that leads to a market shortage of ketamine in 2015. And we see that surge of methamphetamine illegal production, illegal importation also during that year. So we saw that methamphetamine use was probably associated with the Chinese intervention, but also the timely is coincident to our outbreak period from 2015 to 2017. But it's just a postulation. Methamphetamine use with sex has been an interesting topic that also has been addressed in, I think, one of the posters here. And from my data, we look at the shigellosis patient co-infected with HIV, and we did a small case control study as shown in my backup slide, if you can put on my slide back. So for those co-infected with HIV shigellosis cases, we found that more than 60% engaged in chemsex within the past 1 year. And the chemsex was defined as using methamphetamine or mephedrine or GHB, GHL to facilitate sex. And in contrast, the control subjects, which are non-shigellosis patients but HIV positive, only 13% engaged in chemsex in the past 1 year. But 13% or 62%, you can see that chemsex exists in Taiwan.
We have some questions from the floor. Mic 1, please.
Rob Sackleton from the U.S. There was an outbreak also of Hep A in vulnerable populations, especially homeless and IDUs in the U.S., mostly in 2017, which actually caused regional shortages of Hep A vaccine. And do you know if the strains that we're seeing amongst MSM were also similar to the strains seen in the U.S., especially among homeless and IDU populations?
In Taiwan, we don't see a surge of Hep A outbreaks among IDUs. And I think the outbreak in the United States, there is jumping of the virus from either the IDU population to MSM or from the MSM population to IDU. And it's all linked to a lower socioeconomic status, I think, in this area. But my main focus of this presentation is on MSM, so I don't have a lot of research on that outbreak events in the United States regarding homeless or IDU patients. So yeah, thank you for the question, but I don't have good answer to that.
Microphone 2.
It wasn't clear to me the two-dose vaccine regimen that you used. Did that have a history of use prior to the outbreak you described, or did you and your colleagues develop that as a way to address the problem of getting full immunization of the HIV-infected people?
So the 2 doses vaccination is the standard vaccination schedule for children and for adults as well, because the first dose can only provide probably protection up to 1 year or so, but the second dose can boost the immune response further, and we usually say it's either permanent immunity or at least 20 years of durable response in immune-competent individuals. We don't have that good data on HIV-positive individuals yet, but at least now we know the response can be durable in 88% of the HIV-positive individuals up to 5 years. And the research I mentioned about 3 doses was trying to see if 3 doses could work better than 2 doses. But the conclusion is since the antibody positive rate remains similar to 2 doses, there's no evidence that suggests HIV positive individuals should receive 3 doses. But for those who cannot respond, develop antibody response to 2 doses, the 3rd dose can be considered.
Okay, any other questions? If not, thank you again for the great presentation. Then we will move on to our next speaker, and it's my pleasure to invite Karine Lacombe. Karine Lacombe is an associate professor in infectious and tropical diseases department of Saint-Antoine Hospital in Paris, France, and teaches in France and also in sub-Saharan Africa. She clinically and therapeutically manages HIV-infected patients, and she has a PhD in epidemiology, and her special research interest is focused on hepatitis. Thank you, Karine.
Okay, thank you very much. So, dear colleagues, friends, and moderators, I'm very honored to have been invited to deliver this talk today on hepatitis B elimination, and you can see that I have slightly changed the title, because eliminating hepatitis B will imply to target the host and the virus, but with a public health perspective, and it's what I'm going to try to show you during this talk. So first of all, just to set up the scene, go back to some figures. You have here the map of the incidence of hepatitis B in children under 5 years of age, and you can see the number, the total number of patients infected, chronically infected with hepatitis B over the world. And you see that the biggest burden of chronic hepatitis C is found in Africa, Asia, and the Middle East as well, in the Pacific region. And it leads to a total of 257 million patients infected. So how does it translate in terms of disease burden? First, just a focus, because we're here at the HIV conference, a focus on co-infection. So it affects about 2.7 million individuals over the world because of the sheer routes of transmission between HIV and hepatitis B. And those dually infected patients have a higher risk of death, especially after ARV initiation, and mainly in Africa, as we have very recently shown in a paper published in Clinical Infectious Disease. About 900,000 deaths are due to hepatitis B. 66% of the total of death from viral hepatitis with hepatitis C and hepatitis A. About 300,000 from hepatocellular carcinoma, 500,000 from cirrhosis, and about 100,000 from acute hepatitis B. And you can see here from this figure from the Global Hepatitis Report published last year by WHO that the mortality rate from hepatitis is still increasing, while the mortality rate with HIV and malaria are decreasing. And the problem with hepatitis B is that it affects young individuals, women of childbearing age, and with a very high risk of transmission to baby. But we are pretty lucky. I told you just a little bit earlier that it was a neglected disease. It has been neglected for years, but fortunately that has changed. And in the Sustainable Developing Goals for 2030, viral hepatitis elimination is being now targeted. And you see that with this program published by WHO, there are targets to reach by 2030, including hepatitis B and hepatitis C. And there are targets regarding new infections and number of deaths, with a reduction by 2030 of 65% regarding the death, the number of deaths, and the number of new infections by 90%. And you see here, in 2015, there were about 6 to 10 million of infection, and it has to be reduced to 900,000 new infection in 2030. And regarding the number of deaths, 1.4 million of deaths in 2015, reduced under 500,000 of deaths by 2030. So those goals are very ambitious, and we need effective tools to eliminate hepatitis B. Without implementation of effective tools between 2015 and 2030, it has been evaluated by a modeling study that we will have 63 million new cases of hepatitis B and 17 million deaths related to hepatitis B again. So what are those tools that we need to eliminate hepatitis B? First, prevention, then diagnosis, access to treatment, and maybe HBV cure. So, from the bench, first, is HBV elimination feasible? You probably know this picture comparing showing the difference, between hepatitis B, HIV, and hepatitis C. Why did we achieve eradication of hepatitis C? It's because HBV RNA is not integrated in the nucleus, but hepatitis B DNA is integrated into the nucleus in the format of cccDNA, which is a quiescent form of genetic material of hepatitis B. And that's why, like HIV, at the present time with the treatment we have based on the use of nucleosides, we cannot eradicate hepatitis B as we can with hepatitis C. However, the treatment we have now based on NRTIs and mainly entecavir or tenofovir has a very high efficacy to control viral replication. And again, here are some examples from HIV HBV cohort that I am managing in France. These data here are meta-analysis of 23 papers, including all those cohorts on tenofovir. You see that with tenofovir on the long term, we can suppress more than 90% of the patients. However, it does not mean functional cure. If you stop treatment, then viral hepatitis will rebound. And why that? It's because the treatment does not target cccDNA inside the cell, and these results are from the French HIV HBV cohort, where you can see that HBs antigen, while tenofovir is very effective, like in the figure I've shown you before, there is an ongoing presence of HBs antigen at the top of the slide, and at the bottom of the slide you can see that cccDNA, while it is going down, it's decreasing, slightly decreasing over time. It never reaches zero, which means that at some point, we reach a plateau where cccDNA just persists in the cell. And it's due to a new round of infection or replenishment of the cccDNA pool, despite what the so-called viral suppression. That's why there is presently no functional cure. So I will not go through all the HBV cure program. You see here the very complex HBV replication cycle, just to show you the multiple targets that the research is trying to develop drugs to target all those sites in the cycle of the virus. And probably the upcoming strategies that we will need to achieve HBV cure will have to associate antivirals, host immunity, stimulating drugs, inhibitors of HBV antigen production, and cccDNA inhibition as well. So we are quite far from HBV cure, but it's one of the stones that we will need in the future to reach HBV elimination. So, what are the requirements to reach WHO goals by 2030? First, how can we avert new cases of hepatitis B? So we have some clues from modeling studies, and especially this very nice paper published in 2016. So you see here the number of new cases of chronic hepatitis B per year in terms of millions. And you see that if we stay on the status quo, it means that situation we have now, treatment in some part of the world, vaccine, but not very, with not a very good uptake, almost no burst dose vaccine in developing countries, then the number of new cases of Hep B will not decrease at a very large scale. If we just increase the number of vaccine up to 90% of the population in need, then we will slightly impact on the number of new cases of Hep B. But if we really want to impact on the new cases of Hep B, we have to associate HBV vaccine scale-up to 90% and prevention of mother-to-child transmission of hepatitis B, which means at least 30% of the mothers treated plus the burst dose vaccine. And if we add the treatment of cases, then we will impact this curve a little bit more. Now, regarding the decreasing of HBV mortality, which is another goal of WHO by 2030. So what do we need? So you see here, again, the same models and modeling. Here again, the status quo, we will see for years an increase in HBV mortality, but then if we add the vaccine scale up until up to 90%, there will be almost no difference with the status quo. So another way to impact would be to add HBV PMTCT, but you see that it will impact the number of people dying from hepatitis B just on the long term, but if we want to impact quite early and really reach the target by 2030, we need to be more proactive and especially introduce treatment on a large scale. So you see that we have to develop intervention on many steps alongside this program. So first, what is the impact of burst dose vaccine, and especially in Asia, where we have some figures, because burst dose vaccine has been implemented in Asia for years. And you see here, for example, in China, after global implementation of immunization, a very clear impact of the chronic carriage of HBs antigen and the anti-HBs antibody rising in cohorts vaccinated at birth compared to cohorts who did not get vaccinated at birth. And on the long term, when we vaccinate, we want to decrease the number of chronically infected patients, but we also want to impact on the mortality. And you see here the impact on immunization on hepatocellular carcinoma in the long term. And those are data from Taiwan. Very important data, because in Taiwan they have implemented a nationwide program on hepatitis B vaccination in infants. And you see the difference between the patients who had the persons who had been vaccinated and the ones who had not been vaccinated, with a very large difference in terms of incidence rate of hepatocellular carcinoma. However, the burst dose vaccine in Africa is still a challenge. So why that? You know that when you talk about burst dose vaccine, it means that the vaccine has to be administered within 24 hours of life, which is the current WHO recommendation to prevent perinatal HBV transmission. Unfortunately, in Africa, this is achieved only in 11% of the patients. And why that? Many factors, some political factors, some cultural factors. First, the burst dose vaccine is not provided by the Vaccine Alliance or the local governments, so it has to be implemented by the governments or financed by NGOs or by the mothers, but most of the time the mothers don't have the money to pay for the vaccine. And 50% of the women give birth at home or in non-medical centers, and even when vaccines are available in the centers, just the mother do not deliver in the centers. And there is also a problem with cold chain. But the birth dose vaccine is not the only strategy to prevent the transmission from the mother to the babies. And here in this meta-analysis, you see that when you compare the rate of transmission from the mother to the babies in Asia and Africa, and stratified by the presence of HBe antigen, when there is no prophylaxis, the risk in the blue is very, very high. And when you add the birth dose, in Africa, in Asia, it decreases, but it doesn't go to zero. And in Africa, it decreases as well, like in Asia, but it's far to zero. So the best way to do is to add immunoglobulin as we do in rich countries. But you know that in Africa, having access to immunoglobulin is an illusion. And there are no trials in Africa evaluating the impact of adding treatment during the pregnancy, treatment of the woman during the pregnancy. And we have very nice data now coming from Asia and showing that in the context of Asia, where hepatitis B is a little bit different from what we have in Africa, that definitely works and reduces the rate of transmission to the baby almost to zero. So this is definitely, not only probably, but definitely a strategy that should be evaluated in Africa. And in that way, we would probably avert a very high number of children being infected each year in Africa. At the present time, 367,000 newborns are infected with hepatitis B, and it's twice higher than what we see with HIV. One of the reasons why HBV PMTCT is not effective, and especially in Africa, it's because of the lack of screening. The lack of screening is due to the problem to identify a good point-of-care test, for example, to identify the mother who are really at risk of transmitting, which means those with HBeAg positivity. And it's very difficult to have HBV DNA measurement, which is out of reach in most countries. And there is, as I told you a little bit earlier, a problem with political will. Screening is mainly not provided for free, and sometimes it's not, the cost of screening is not bearable by the family. So it leads to the problem in identifying those who are in need of treatment globally. Treatment eligibility and coverage is definitely a very challenging issue, and you see on this figure, on the left of the figure, the patients infected, and this is a cascade of care, a global cascade of care, and you see that we have a lot to go in terms of diagnosis, in terms of treatment, and of course in terms of viral suppression. So in 2018, well, that's data from 2015, but I'm not sure that in 2018 we are the situation is very different from what we have on this figure. We are very far from reaching HBV elimination. Only 9% of HBV infected patients are aware of their status, and about 10%, 5 to 9% of the screened patients in Africa are in need of treatment, and among those patients, only 8% have access to treatment. So you see we have a tremendous work to do to achieve the goals. What are presently the WHO guidelines for global HBV screening and treatment? We have tried to define I wouldn't say a basic algorithm, because you can see that it's kind of complex, but we have tried to stick to the most common situation, and especially where it's very difficult to have fibroscan, for example, to evaluate liver fibrosis, or even HBV DNA to identify the patients who are in need of treatment. And you see that those patients who are in need of tenofovir or entecavir, in most cases we need HBV DNA, and it's very difficult to decide which patients to be treated, except those with cirrhosis, if we don't have access to HBV DNA. So it's probably one of the main limits now for HBV elimination, the access to molecular tools adapted to low and middle income countries. we have some clues and some tools that are being developed. For example, the use of dried blood spots for HBV DNA. In that way, we can, from decentralized centers, send the DBS with HBV DNA to be analyzed in centralized laboratories. And you see that sensitivity and specificity of DBS for HBV DNA quantification is quite good. And presently, a few quantitative or semi-qualitative PCR in-house, especially, are being developed with a quite low cost. And you see that with those tools, we could probably implement the former algorithm from WHO. And we are hoping to have point-of-care HBV DNA, for example, with a GenExpert or any other kind of device in the near future. And it will really help to reach HBV elimination. I told you that not all the patients are in need of treatment, so we have the problem with screening, and we also have the problem of identifying the patients who are in need of treatment, because at the present time we don't have any cure. It's not like with hepatitis C, where we have to treat everybody to reach elimination without a perspective of a vaccine, but with hepatitis B, since we don't have cure, we have to identify those who are in need of treatment to decrease HBV mortality. And some colleagues are developing very basic and easy to use algorithm. So you see here, this paper is has been published in the last past days. For the evaluation of treatment eligibility, you see that the score, TREAT-B, based, very, very easy, based on ALT and HBe antigen, which means that we have to have access to HBe antigen screening. Then when the score is above 2, the probability that the patient is in need of treatment is very high. You see here the performance of this score, TREAT-B score, compared to the EASL guidelines and the WHO guidelines. And on the same slides, but I do not have time to go through that, you see another score called REACH-B, which is a score to predict the risk of end-stage liver disease. And you see here that this score, based on ALT and HBe antigen, can, with a very good performance, predict the need of treatment and the risk of severe liver disease on the long term. See here the sensitivity and specificity. So some take-home messages, last slide to finish my presentation. There is a very complex interaction between the host and virus, and in the absence of drug for cure, not all patients have to be treated. So this is one of the limits for HBV elimination. We have no cure to date, but we have a vaccine. So the vaccine should be implemented globally on the best way possible, and especially by implementing burst dose vaccine on a large scale, which will be a very important, essential step towards HBV elimination. And HBV elimination will be the addition of immunization, especially burst dose, the screening based on point-of-care test, HBV PMTCT, effective HBV PMTCT, including the treatment of the mothers and especially those with a high viral load, and universal access to HBV drugs, and maybe in the future HBV cure. So probably HBV elimination will not be reached by 2030. We'll be very lucky if we can do that for hepatitis C, but we have a lot of steps to go through for HBV elimination, and it will need all the community to invest in a matter of money, human resources, and science as well. And I'd like to acknowledge the help of 3 colleagues who have reviewed the slides and provided me with some papers. And for those of you who are interested in hepatitis, viral hepatitis, and especially viral hepatitis in Africa, there will be for the first time a conference completely dedicated to viral hepatitis and liver disease in Africa called COLDA. It will be held in Nairobi, Kenya in September. So I suggest you to go on the website, COLDA, and look for the program. It's very interesting. Thank you very much.
Thank you, Karine. And we have to close the session. Thank you to all the speakers for the excellent presentation. Thank you all for being here at this symposium, and we wish you a very nice evening.
Great. Well done.